So I'll start with this slide. It's a little busy, and I left it that way because, as David McAdam and I were talking about, surgery is busy, and it's difficult, and it's confusing, and we were just saying maybe that's why it's been kind of underappreciated in the global health world. But in the next maybe 20 to 30 minutes, I want to talk to you about the Lancet Commission, how that fits in with the SDG era and universal health coverage, those concepts. And then you'll notice my title is a little bit unusual. I said Cambrian Evolution in Global Health. And so the Cambrian period on the planet was about 400 to 500 million years ago. And that's when we first had vertebrates. And so my underlying thesis to my whole talk is that global health requires a skeletal structure that is surgery, anesthesia, and obstetrics. That provides a horizontal foundation upon which a properly functioning healthcare system can work. So we'll start there. Now, I don't know if you've seen something like this. It's a bunch of experts here, and they're feeling a different part of the elephant. And of course, one person thinks it's a rope, and this person thinks it's a wall, and this person thinks it's a snake. Well, you know, global health is like that, all right? So you have some people that think it's all about women's health, and you have the Gates Foundation that thinks it's all about infectious disease and primary care, and you have me, I feel something sharp, and I say, well, that's surgery. And then, how did I know this woman was an anesthesiologist? She's trying to nasally intubate the elephant. So my point here is that we all get caught up with our blinders on and we think, okay, this is the important thing, but you lose sight of the fact that it's the elephant that's important. Now I want to drive that home one more way. So I don't know if you've heard of her, Salome Karwa. She was a nurse's aide in Liberia, and she actually survived Ebola, all right? So she was one of the people who survived Ebola. Amazing. So a couple years later, I wrote an article about the importance of holistic health system strengthening. And I started the article in this way. I said, earlier this year, 3 days after giving birth to her fourth child by cesarean section, Salome Karwa had sudden convulsions. When she was admitted to the hospital in Liberia, the staff panicked as she was a famous Ebola survivor. Karwa, a nurse assistant, died the next day, likely from an easily treatable complication from surgery. She survived Ebola, and she dies from a C-section. All right, that just is so strange that we can live in a world where that happens. So, a little bit about evolution. Now, thankfully, I won't start in the Cambrian period. I won't take you through 400 million years. Maybe my talk will seem like it's that long, but I want to start in 1980. So Halfdan Mahler, he was the Director General back in 1980, and he was one of the first, if not the first, international leader who linked surgery and health equity and social justice. All right, so if you look at his comment there, the vast majority of the world's population has no access whatsoever to skilled surgical care, and little is being done to find a solution. I beg of you to give serious consideration to this most serious manifestation of social inequity in healthcare. So he directly linked surgical care, health equity, social justice. In 2008, I'm sorry this is a little bit small, but this is Paul Farmer and Jim Kim. So Jim Kim is now the president of the World Bank. Paul Farmer started Partners in Health with Jim Kim and Ophelia Dahl. And they're both ID docs, and they wrote an interesting article in the World Journal of Surgery in 2008 where they called surgery the neglected stepchild of global health. And it's interesting how that metaphor resonated. You really can't go to a global surgery meeting without someone talking about how surgery is the neglected stepchild of global health. And that was in 2008. So we started in 1980, came to 2008, 28 years later. And then in 2015, there seemed to be some momentum. And so Disease Control Priorities 3 was published with the World Bank. It's a 9-volume series, all right, and the first volume was on surgery. So that's a moral victory, if nothing else. The Lancet Commission came out, as David mentioned, and probably most importantly, the WHO, for the first time, verbally and explicitly recognized strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. Believe it or not, that was the first time that the WHO said surgery and anesthesia ought to be part of universal health coverage, as if it didn't exist before. But I'm glad that they did that. That was a multinational effort. And that was 3 years ago, so what's happened in the interim? Well, let's go back to 2015 just for a moment. David mentioned the Lancet Commission. So this is Richard Horton. I give him a tremendous amount of credit. I think he's been visionary, and one of the things that he's done is start this concept of commission. So as you know, the Lancet has a commission on something related to global health maybe once a year. In 2013, he asked a group of us to chair a commission on global surgery. So Andy Leather from King's College and Lars Hagander from Lund. And we quickly put together a group of 25 people. And when he met with us the first time, he said, I want you to look at the different aspects of surgery, and I want you to make a diagnosis. What are the issues and problems, et cetera, but just don't write a paper about all the problems. What are some of the solutions? And he said, I want some key messages, four to six key messages, and some indicators. And then one thing that he didn't specifically ask us to do, but what we did towards the end of the commission process was add this concept of a national surgical plan, and I'll talk about that in a moment. So when we met as a group, one of the first things that we did, which turned out to be a very good idea, was we came up with this vision: universal access to safe, affordable surgical and anesthesia care when needed. A, it's good to have a vision for any organization, and B, you'll see this played into one of our key messages, and notice the multifaceted aspect of the vision. Now we did as we were asked. We came up with 5 key messages. You don't have to read these right now. I'm going to go through these with you in just a moment, but we came up with 5 messages, one around the fact that 5 billion people lack access, another, how many procedures more were needed, how many people were facing catastrophic expense, the fact that surgery is an investment, not just a cost, and the fact that it's really an indivisible part of healthcare. It's not a vertical thing that you do on the side. So I want to let you listen to Jim Kim. He does such a nice job in just a minute or two summarizing those 5 key messages, and then I'm going to unpackage those a little bit for you.
Thanks so much, John. Greetings to everyone, and sorry that I can't be with you in person. Congratulations especially to the Lancet on the release of Global Surgery 2030. Today, an astonishing 5 billion people cannot get safe, affordable surgical and anesthesia care. 90% of people in low and lower middle income countries can't even get basic surgical care. The Lancet's report shows us how we can close this gap. Its proposed time-bound indicators, for instance, are critical. They can motivate governments to provide the universal and affordable surgical and anesthesia care that people deserve. The stakes are extremely high because failing to fix this problem will have a substantial impact on people's lives, well-being, and even on their economic health going forward. 33 million people face catastrophic health expenditures due to payment for surgery and anesthesia care each year, and an additional 48 million cases of catastrophic expenditures are attributable to the non-medical costs of accessing surgical care. That's 81 million people that are plunged into poverty every year. There's also evidence that low and middle-income countries will suffer enormous losses in economic productivity over the next 15 years if this access gap persists. For these reasons, the Lancet report's findings make an important contribution to global public health. They're also an essential step to people living healthier, happier, and longer lives. It shows that we have to think in a fundamentally different way about healthcare and surgery's role in it in developing countries. Not only is access to surgery the right thing to do morally, it's also important to ending extreme poverty and boosting shared prosperity. I want to thank my good friend John Meara for his leadership on this effort, and thank everyone at the Lancet for doing such good and important work for the poorest people on the planet.
So Jim did a nice job. He went through the 5 key messages. I just want to unpackage those a little bit for you so that you know where those came from. So the first key message that you may have heard about: 5 billion people lack access to safe, affordable surgical and anesthesia care when needed. So we used our vision, all right? Now, the reason this is important is that in the past, maybe 5 or 6 years before that, Atul Gawande's group from the Brigham had said that 2 billion people didn't have access to surgery. And it was actually Paul Farmer in our group who said, you know, I've traveled around the world and I just find it hard to believe that actually 5 billion people have excellent access to surgical care. And so, and to go back to Atul's group, they looked at operating rooms and operating room density. And we started to talk about our vision and said, well, you know, access to surgery requires more than just that. So So what we did, I'll show you here, the other point I want to mention is, it's really important to mention, it's not equally distributed. So 5 billion people don't have access, and the people who are disadvantaged are often the young, the elderly, the disabled, women. So it's not an equal distribution of people who don't have access to surgery. So here's what we did. We had some modeling folks, and this is what they did in equation form, which is kind of hard to understand and boring, but it's called a joint probability analysis. They said, what's the probability that they have timely access, that you go to a facility that has capacity, that it's safe, that they can afford it, all right? So that's the equation, but you have to remember, you actually have real people, and they're trying to get to real hospitals. And they have to jump through these metaphorical hoops. So I was just in Mexico, and you have people who are literally 18 hours away from a hospital, all right? That's not real access. Now, if they can get there, they might show up at a hospital that doesn't have capacity, doesn't have running water, it has electricity 20% of the time, all right? Now, if they can jump through these two hoops, they might get there and find out it's really not a safe facility. They don't have a culture of safety, they don't do M&Ms, they don't have a pulse ox, et cetera, et cetera. And then the one that really gets most people is the affordability. All right, so people have to jump through these four and more. I mean, this is a simplistic model of access to surgery. It's, as David will talk to you about after my talk, you'll see it's even more complex, obviously, than this. The other thing we looked at in terms of how we structured the Lancet Commission is we borrowed something from the OB literature. So this is Thaddeus and Main's article, and this is where that concept of the 3 delays came from. This is the original article from 1994. And what they did is they said there are reasons that people don't get OB care, and we said it's probably the same for surgery. There are delays in seeking care, right? So why don't people seek care? And so you'll see in the Lancet Commission, we use that as a framework. Why do people have delays in reaching care? They want to get there, but they can't get there for all sorts of reasons. And then once they do get there, there are delays in receiving care for some of the things that I just mentioned to you, and I'm sure David will have some great stories about people having issues here as well. Now, one thing that we did in the delay in receiving care is, and the reason we did this is we had ministry folks on the commission who said, you know, I need to be able to tell my ministry, what does a real district hospital look like? What do we have to do to it? Is it numbers of procedures? Is it electricity? You know, give me a list of things. And we said that's awfully hard to do. We said, why don't we look at the WHO data and look at district level hospitals, and are there things that are predictors of a hospital that can provide a broader range of surgical care? And what we found is that hospitals that could do these 3 things, these acted as somewhat as bellwether procedures in the sense that hospitals that had the staff, stuff, systems, and space to do these generally was kind of what a district hospital ought to look like, all right? And we didn't want to be prescriptive. So this concept has stuck around too, this concept of bellwether procedures. And this really speaks to an economic term of economies of scope. So once you have a district hospital that can do these things, doing a little bit more, the marginal cost and the marginal difficulty is not that big once you have this type of a foundation at the district level. Now, if you turn all the things that I've been talking to into a heat map, these dark red areas are areas where nearly 100% of the population does not have the same kind of access that you and I do. You know, if I trip later tonight and fall off here and break my ankle, you'll have me taken care of in 90 minutes. That's just not true where I was in Mexico and many other places around the globe. Second message, 143 million more procedures are needed each year. Well, just to give you a frame of reference, there are about 330 million procedures performed each year. But again, it's not an even distribution. The poorest 1/3 of the world receives 6% of the procedures. So the poorest 1/3 gets 6%, and the richest 2/3 gets all the rest. Now, why is that? One of the reasons is workforce. This is a little bit busy, but I want to walk you through this. This is an important concept as well. We, again, worked with the WHO with their workforce group, and we came up with this concept of SAO density, surgeons, anesthesiologists, and obstetricians. On the x-axis, this is SAO density per 100,000 people. And on the y-axis, this is life expectancy. And we did this with a number of different variables from the World Bank. You can pick under 5 mortality or maternal mortality, and the curves look basically the same. And the concept is this. You notice that things look different in countries that are over 20 surgeons, anesthesiologists, and obstetricians per 100,000. For example, no countries have life expectancies over 80 unless their SAO density is greater than 20. And also, in the countries that live in this area, none of them break above 80. And as I said, their maternal mortalities look like this, they're under 5. Now, the one thing I'm very quick to mention when I show this slide is this does not prove causality. And of course, we talked about the multifactorial nature of surgery. Simply scaling up and training a bunch of folks, that's not going to solve the problem. But again, this is somewhat of an indicator of these systems look and feel and function differently from each other. All right. Key message 3, 81 million people face catastrophic expenditures paying for surgery. Now, 33 of them, they face catastrophic expense just paying for the procedures themselves. But what we often forget is that 48 million people actually face catastrophic expense for transportation and food and other things not related to healthcare. Now, why is that? Well, not hard to understand that concept when about half the world lives on $250 a day. So if you have a femur fracture and it's a couple $100, that's a catastrophic expense for you. This was a very important message, and we came upon this late, actually, and we had a couple ministerial folks, ministries of health, who said, look, we get it. We understand health equity, social justice, but I need to walk across to my minister of finance and talk to him or her and say, hey, we need more money for this. So we need some economic arguments. And what we came to find out, and I'll show you this in a minute, is that this is really an investment. It's not just an expenditure, and it is affordable. It saves lives. Surgery, anesthesia, and OB saves lives, and it does lead to economic growth. We modeled what it would cost to take all low and middle income countries up to kind of a middle income country level of surgery. And it's an enormous amount of money over 15 years, $350 billion, all right? But when you look at the potential economic gains, so putting a 17-year-old with a femur fracture back into the workforce, that can be on the order of 12.3 trillion. And this just wasn't our commission that found this type of a finding. The commission right before ours, the Commission on Investing in Health, Larry Summers and Dean Jameson, they found the same type of thing. So it seems intuitively obvious to our group, but healthy people lead more economically productive lives. I mean, there's something to that. This key message came right from Jim Kim's mouth. So at our very first meeting, he gave us a video address, and he said surgery is an indivisible, indispensable part of healthcare. So it's not something separate. It shouldn't be a vertical thing that you do over here. It has to be wrapped in your entire healthcare system. I would say the one mistake we made is our key message was surgery is an indivisible, indispensable. What we should have said is surgery, obstetrics, and anesthesia. I think that trinity of specialties is really very important. And again, why? Well, roughly a third of human disease requires some knowledge about either surgery or OB or anesthesia. All right? So it's a huge preponderance of human disease that requires that type of expertise. Now, I told you before we had been asked to come up with indicators, and we did. So we came up with 6. 2-hour access. What percent of your population is within 2 hours of a hospital that can provide those bellwether procedures that I talked to you about? What is a country's SAO density? So basically, what workforce does each country have? What is the country's surgical volume? What is the perioperative mortality rate? So how many people are dying after surgery? And then we had 2 related terms that deal with both impoverishing and catastrophic expense, and they have some subtle differences, but they basically look at what are you doing economically to people in order for them to receive their surgery. And we also, towards the end this was a late comer actually, we came up with this concept of national surgical obstetric and anesthesia planning, and we originally had 5 domains, and I will tell you this story in just a moment. Tanzania very recently added governance as the 6th, and I think that was very smart, and so we're actually expanding to 6 now, because if you don't have a governance framework around this national surgical planning process, the wheels come off of it. So now we're in 2018. I want to talk to you just a bit about indicators, some of the successes that have occurred, and then I'm going to talk to you about the national surgical planning and what's happened since then. I'm going to borrow a few slides from a friend of mine, Emi Suzuki. She's at the World Bank, and she is in charge of a group that handles what are called the World Development Indicators. And I didn't know about these 4 or 5 years ago. They're extremely important, and I'll show you why. So the WDI group at the World Bank, they collect indicators on everything. It's amazing. Over 1,500 indicators: labor, education, debt, trade, commerce. They have a huge health section. They collect data from over 217 countries and economies. All right, so this is a massive ongoing effort. They have dozens of people in DC working on this all the time. And this is what the site looks like, or this is what it looked like in 2015. So they print a book, but then they also have an online website that they now update, I think, 3 times a year or 4 times a year. And when you go to the website, here's the health section, but there's an infrastructure section, and there are 15 different sections, as you saw on that grid. Now, you notice something here. You have life expectancy of teenage mothers, you have prevalence of HIV, adolescent fertility rate, but there is nothing related to surgery or anesthesia. And I had an economist at one of the meetings. He's actually an environmental economist, and he came down after the meeting and he said, you know, you really need to concentrate on these WDIs. And at this point I said, what are they? I don't even know what those are. And he explained this to me, and he said, in environmental economics, we had the same problem that surgery had. Nobody was paying attention to it 20, 30 years ago. And we started to get data. We lobbied the World Bank, and we started to get data in the World Bank. And what we found over the next decade was then people started doing their master's theses on things related to the environment. People did their PhD work on things related to data that was in there, because what I didn't tell you is if you click this, these are all active links. You click that, and a huge Excel spreadsheet opens up with years worth of data. So people who are doing theses, they can do all sorts of research looking at the impact of one thing on another, or health data on infrastructure, or the other way around. So this is a really powerful database. Well, fortunately, in April of 2016, the World Bank provisionally accepted the 6 indicators. They published 4. Now, why did they only publish 4? Because, come to find out, you really can't get this data right now. Countries don't know how many people are dying after surgery, and really countries don't know exactly where their populations are and where their hospitals are. All right, it seems like relatively basic information, but you can't go to very many or any ministries of health right now and say, you know, could you please show me that data? Now, I give the World Bank a lot of credit. They've been blogging about surgery, which would not have happened before 2016. Emi Suzuki herself wrote on the data blog. This blog apparently goes to several million people. So these are people who, by and large, were in the global health community, never talking about surgery, OB, and anesthesia. And now they see Emi, who they know, writing about this. That's a huge moral victory. Also on Twitter, the same thing. So this is her group, the World Bank data group. And even this is the World Bank at large. This is their Twitter site, and they've been tweeting about surgery, anesthesia, and OB. So these are, they don't seem like that big, but it really is a big deal, because you have global health people now who are seeing this and saying, what is this about surgery? We've never heard about that before. And this I'm really happy with. So Emi's group produces the Atlas for the Sustainable Development Goals. So we had the MDGs, and then the SDGs came after the MDGs. And the World Bank publishes this every year. Well, of course, surgery and OB and anesthesia never had anything to do with the MDGs or the SDGs until this year. We have an entire page. Page 12 is all about surgical workforce, surgical obstetric and anesthesia workforce. So again, you're going to have all of the global health world who is waiting anxiously for the hard copy of this to show up on their desk. And now they're at least going to see something about surgery, OB, and anesthesia. So now, national planning. This is what's happened just in sub-Saharan Africa. So these are countries who have said, hey, we like that idea. We want this type of a plan to be incorporated into our national health plan. And I'll tell you a little bit about how that started. David McAdam and I were talking about, we have a common friend, Emmanuel Makassa, and a couple of you have heard me tell this story, but I love it. We were at one of our last Lancet Commission meetings, and it was a very long table. And we were talking about the national surgical planning, and at that point, it wasn't even going to be part of the Lancet Commission. And we talked about it, and then we went on to something else, and about 20 minutes later, Emmanuel Makassa was at the end of the room, and he was just holding his hand up. And I said, yes, please, speak, Emmanuel, what do you want to say? And he said, I have just been texting my government, and we will be the first country that works with the Lancet Commission on a national surgical plan. And then a couple of us looked at each other, and my first comment was, I wish I could text my government. actually, but now I'd have to tweet my government, given what's going on. So, I give him a lot of credit because, boy, he rolled up his sleeves and he made this happen. He was the champion behind the scenes. Our group was helping, but we'd run into a roadblock for a month or two, and I would send him a WhatsApp message, and boom, 5 minutes later, my team would call and say, gosh, someone from the ministry just called, and they're going to help us with whatever they weren't going to help us with. So that's what you need. Now, so this was one of the first countries we worked with. This is the last country we've worked with. They just literally printed this and signed this into law. This is Tanzania. And I'm going to show you a little bit about this. What I want to show you is what a fantastic job they did, how thorough they were. So they started with a literature search. They got clinicians together, civil society, NGOs, government, got all of these folks together in a huge workshop over 2 days. They broke into 5 groups with different topics, and they came up with a huge volume of information. They then gave this to a smaller writing group who literally sat down for a week and just ground through all this and wrote a rough draft. They took it across the hall to their finance folks, who then costed that out. And then they revised it, and the final draft was signed in December of 2017. And I want to show you a little bit about what they did. So they took those 6 domains. Remember I told you that the Lancet Commission had 5 domains, and they added governance, which I think was a very smart idea. And I want to show you one domain. You don't have to read all this, but what I do want to show you is that they had recommendations for every domain. So define expected surgery, anesthesia, obstetric, critical care service package at each level of care. All right, so they had recommendations, but then the next layer down, they had strategic objectives for each recommendation. So for each, this is one recommendation has these objectives. Each of these objectives has data that goes with it. So they were very thoughtful. They had recommendations, they had objectives, they have data that goes with that. And they did that for every domain: service delivery, infrastructure, workforce, information management. Whoa. Let's go back here. Finance, governance. They did it for all of the domains. And then they took it to their finance people across the hall, who then costed every aspect of that. So this is service delivery in 2018. This is service delivery in 2019. If you come across here, this is what they want to spend for service delivery. This is what they want to spend for infrastructure. You can also look at the bottom here in US dollars. This is what they want to spend the first year, the second year, the third year. And you can see over here, it's 600 million US over 7 years. And you think, that's a lot of money. 600 million over 7 years. But you know what? When you look at their population, that's $1.70 per person per year. And this is a point that is being talked about more and more, that we're not asking countries to spend an exorbitant amount per person. It's shifting a little bit of their national income towards health promotion, healthcare delivery. It's 3% of their healthcare spend, not of their total GDP. It's just 3% of their healthcare spend. So we're not asking for a ridiculous amount. Now, this is Permanent Secretary Mpoki. He's the Permanent Secretary in Tanzania for Health. Come to find out, he's a brilliant tactician. So he said, I'm going to have an official launch for this document. And when am I going to do it? Well, in the EXA community, East Central and Southern Africa, there are 10 countries. The EXA health ministers meet every year in a different city. Just so happened this year, the EXA health ministers were meeting in Dar in Tanzania. So Mpoki says, I'm going to have the launch at that meeting. And here he is giving a hard copy to all of his colleagues, all of his minister colleagues, and all of his permanent secretary colleagues in other countries, so they go home with this. And it was Emmanuel Mukasa who told me, once a couple of us start doing this, our neighbors, there's a little bit of healthy competition, are going to say, hey, if Zambia can do it, if Tanzania can do it, we can do that too. And so that was exactly why he was doing this. 2 days later, the WHO, Walt Johnson, and some folks from Harvard had a meeting in Dubai, and we invited a number of countries to come for a workshop on national surgical planning, and didn't know who was going to show up. 20 countries, 80 people came, all right, and what came out of that? They made a commitment to show up at the CASEXA meeting in December to show each other what they had accomplished in those number of months, all right? And I thought that was really good, getting the community together to start to benchmark against each other. The other thing that came out of that, as a group, the 80 people came together and said, let's write a policy brief that both discusses what we did and gives some guidance to other countries and other regions that want to do this. And then the last thing I'll show you about information about national surgical planning. This is our website, and we've been hosting all of the data and plans and everything that comes out of this. So Ethiopia, Zambia, Tanzania, Nigeria, anything that's come out of this whole year-long process in those countries, you can click this and get those documents. And then these are all the resources. So surgical assessment tools at the district hospital level. These are all freely accessible for countries who want to do this. You can just download all of this. And then the World Federation of Societies of Anesthesia, a week or two ago, just posted this. They have a fantastic anesthesia facility assessment tool. It's online. You can get the PDF, but you can also do it online. They have an online version of this if you're somewhere that has internet access. So we're starting to see more tools, regions coming together. It's really amazing the momentum that we're starting to see. In terms of the things that I'm going to keep my eye on for the next several years, it's scaling up this national surgical planning effort. Data. Data has to be linked to the plans. The plans have to include data. This has to flow upstream to the WHO and to the World Bank. If we aren't transparently reporting on what's happening, and that's why Richard Horton wanted indicators. He said we need transparency around what's happening in these countries. Regionalization. So doing this one country at a time is not the way to do it. I love seeing the fact that the EXA community, the Western African community, I didn't tell you about that, but the WACS wants to do this for the West African community. So I love seeing what's happening now. Regions are coming together, working together. There's a Latin American group that's starting right now. Walt Johnson at the WHO wants to start the same thing in Asia. And that's the only way to scale this. We can't do it country by country. And then funding, by funding, I don't mean I'm going to ask you to pull out your wallet and give us some money for this, but what I really mean here is that the major funders like the World Bank, the Gates Foundation, as David McAdams and I were talking before I started, they've only been funding certain kind of pet vertical projects, and we really need to think more about horizontal health system strengthening with surgery, OB, and anesthesia as an integral foundation to all of that. And I want to circle back to my elephant. So I don't want any of us to forget, I've been talking to you for a little too long about surgery, OB, and anesthesia. But the elephant is social change. And we have to change, as Jim Kim said, the way we look at healthcare delivery, of fundamentally changing the way we deliver care and surgery's role in it. That was his quote. Also, regional healthcare. We talk about pandemic preparedness. We will not achieve pandemic preparedness by preparing for pandemics. That sounds like an odd statement. You can only achieve that by having health systems that work all over the world. There are reasons why certain countries in Africa really got hit hard by Ebola, because some countries had stronger health systems and could deal with that. And lastly, we really have to think about equity, not just equality, but equity, because everyone needs to bear the fruits of this healthcare delivery system. Otherwise, you don't get the economic gains. You don't get all of the pluses that come with this unless you incorporate equity into this discussion. So with that, I will thank you, and I will tell you also that I'm going to post this talk on Twitter here. You may use any part of it. You can change it. There's nothing proprietary about this, so you're free to download that. So thank you for allowing me to talk.